Today in series of Docplexus KOL interviews, we have with us Dr. Massimo Porta. He's a professor of internal medicine at the Turin University in Italy. He was granted his PhD at the Royal Postgraduate Medical School, London University in UK in 1983, where he worked on diabetic eye disease. Currently, he's the head of the unit of internal medicine and of the Diabetic Retinopathy Center. Professor Porta is a past president of the study group on eye complications of diabetes of European Association for the Study of Diabetes and convener of working group of the St. Vincent Declaration for the Prevention of Diabetes-related Blindness in Europe. Professor Porta's research interests include the pathogenesis of diabetic retinopathy, prevention of diabetes-related blindness, and group care, a new model to manage chronic diseases. Professor Porta has authored many papers in indexed journals. He's the editor-in-chief of Acta Diabetologic. Thank you, sir, for the interview. So let's begin with the first question. Doctor, I would like to know the management therapies for diabetic retinopathy.
Okay, we need to manage blood glucose, blood pressure, and screen. Regarding blood glucose, we aim at keeping hemoglobin A1C, diabetes control, as close as possible to 7% or 53 millimoles throughout the patient's life. And this we do by either insulin or any of the drugs that are available nowadays. This is not always possible. In fact, often it is not possible to achieve such good control if we don't want to have too many hypoglycemic episodes or other problems. So we strive to do the best we can. The patient strives to do the best the patient can, of course. And so this is the first measure. The second is managing blood pressure. We want to keep blood pressure not higher than 130/80 millimeters of mercury. And again, we have a number of drugs, of pharmacologic agents that can help us. And that is, in a way, more feasible than keeping blood glucose under control. So it is mandatory to keep blood pressure under within targets. Thirdly, we must screen for retinopathy by photographs, by ophthalmoscopy, whatever means is good as long as it works. We we screen for retinopathy at diagnosis of diabetes, because in the case of type 2 diabetes, we may have between 10 and 30% of patients already with retinopathy. So this is an important message to give to the patient. Secondly, if we do not find any retinopathy at first screen, we screen every 2 years. And if retinopathy appears, then we screen more frequently or refer the patient to the ophthalmologist, depending on the severity of what we find. Other possible agents that might influence retinopathy include fenofibrate, which is a drug that lowers blood lipids, triglycerides. Fenofibrate may reduce progression of retinopathy or even prevent sight-threatening retinopathy, but it is not approved for use except in very few countries like Australia and New Zealand. So we use it off-label if we believe we can use it. And there may be a word of caution for glitazones, because glitazones may cause fluid accumulation into many tissues, and that might include the retina and cause diabetic macular edema. So we might, one caution if a patient has retinopathy might be to reduce or stop pioglitazone.
Right. So moving on to the next one. What is the frequency of diabetes-related blindness?
Diabetes is the first cause of blindness in working age, between 16 and 64 or something like that in industrialized countries, and one of the main causes of blindness at all ages. It is, interestingly, the first cause of preventable blindness. So that is why we must do screening systematically.
So, doctor, moving on, what is the current research scenario in diabetic retinopathy?
So it's a good question. There are many fields of research, from the research on the pathogenesis of retinopathy to research on the best way to organize prevention. So talking about the translational aspects of research, there are a number of studies on the mechanisms that might lead from high blood glucose to damage of the capillaries of the retina. That includes cells like endothelial cells and pericytes, which are the cells that reside within the wall of the capillaries and are also first damaged in the natural history of diabetes. There are a number of mechanisms, including aldose reductase, to the position of advanced glycation end products, to products of oxidation, to activation of protein kinase C, and a number of other mechanisms that derive from these. And there are a number of possible effects of this research. In particular, some of these mechanisms lead to the generation of a vascular endothelial growth factor. VEGF is a secondary product, and when it is normally a neuroprotective agent, so it is per se a good agent to have in the retina. But when it is overproduced, it causes increased leakage or permeability of the vessel wall. That leads to fluid accumulation within the retina and edema, or growth of new vessels, therefore proliferative retinopathy. Both are the sight-threatening stages of retinopathy. So nowadays we use antibodies against the EGF, which are injected directly into the eye. And so the intravitreal injections of anti-VEGF agents are very helpful in reducing blindness or treating retinopathy once it has reached the sight-threatening stages. So this is a direct effect, direct consequence of research on the basic aspects. In terms of prevention, as we said before, we need to screen. Screening is done more and more with digital photography. And there are nowadays very interesting applications of neural intelligence, artificial intelligence, interpreting the photographs of the eye and being able to make at least assisted diagnosis of retinopathy. Because if we think of the millions of people with diabetes throughout the world who all need to be screened, we also need an incredible number of people looking at the pictures, looking at the photographs. So having the assistance of artificial intelligence, of information technology to assess the picture will enormously help to reduce the burden of blindness in diabetes.
Exactly right. Thank you so much for the interview. It was a pleasure having you here.
Thank you.
Thank you.